box. And as I did say earlier on to most of you as well, that I'll be recording today so we can use it on the website and other people can listen in, because there has been quite a big waiting list for today as well. So that's enough of the technicalities, I hope, but if there's any problems, just put a note in the chat box to me and I'll sort that out. So what I want to do is just say one thing before I pass over to our presenters. And that is in front of you, you'll probably see a slide, you should see a slide, which is described the engagement cycle. And it's a reminder to all of us that there's an obligation on the NHS for patients and public to be involved at all those 4 stages of commissioning work from various providers in the health service. So we hear a lot about patients and public being involved in, for example, improving services, in closing hospitals and so on, and many of us on the line have been involved in that ourselves. What today is about, what today's seminar is about, is not how to do engagement. I'm just going to put somebody on mute there, but in fact about the assurance processes to make sure that the appropriate people in the NHS are doing that engagement. So that's the purpose of today, and obviously our speakers will say a lot more about it in a moment. So the approach today is about how do we know that engagement is happening? How does the NHS know for itself? What's its assurance processes? And how can you, whatever your background, get involved in checking and ensuring that happens really well for you locally? So I'm not going to say anything more about the content because clearly our speakers are going to. So down in southwest of England, we have Nikki Thomas and Tobin Savage, who work together for NHS England in the Southwest office in Saltash. And for those of you who go on Cornish holidays, you know Saltash is known as the other side of the river from Plymouth, which is probably not a very flattering description of it. But as we know, a lot of you from the whole of the south of England, so obviously their talk and our presentation is going to be about the process in general, but they're based in the southwest. So as you can see here, we're going to have a quick 10-minute session from Tobin about what the process is that NHS England manages and runs to assure themselves that CCGs are doing engagement well. We'll have a short break for questions and answers, just 5 minutes or so, just to loosen up and get us thinking about it. And then Nikki, Tobin's colleague, is going to be looking more about the kind of evidence that is used. And the important question for many of you, I think, is, well, how can we be involved? Whether, as some of you here are from GP surgeries, from patient participation groups, we've got people here on the seminar from CCGs, of course, and from NHS. I may have missed 1 or 2 areas too. So we've got a nice mix, and we want this to be a really practical session. So for the last 25 minutes of the web seminar, will be a chance for you to be. Hold on a minute. I think I'm got Sandy uploading her. Yes, so that's interesting. Okay, the last 25 minutes will be questions and answers. So just to tell you how Tobin and Nikki are going to be dividing up their work, the first 3 parts of this content of Tobin and Nikki are going to be run by Tobin, and then Nikki's going to carry on with the rest of it. So I'm going to now pass over. Please just, by the way, make sure you're on mute if you need to be. I'm going to pass over to Tobin and Nikki, and so Nikki's going to introduce herself, and then she's going to pass over to Tobin, who is going to start our presentation. So over to you, Nikki. You are control of your slides, I think.
Fabulous. Good morning, everybody, from sunny Saltash. My name's Nikki Thomas, and I'm the Patient Experience Manager for the South West. And sitting next to me in our small office is Tobin Savage. Hi. He is the Operations and Assurance Manager. So he'll get us going today with what is assurance and what might be our roles in it. Tobin.
Thank you, Nikki. Thanks, Martin. If I can just make these slides work, I think I'm almost there. So, Yeah, thanks for the opportunity to be able to talk to everybody about PPI. I mean, I don't know if people are like me, but I mean, I've worked for the NHS for quite a few years now, and PPI has always been something, not that I'm necessarily sort of centrally involved in or a core part of my work. It's always sort of been a peripheral thing for me, and it's only recently that when I started working for NHS England in a more governance-based role with Nikki and some of her fantastic colleagues, I have to say, that I began, well, Nikki's a great champion of PPI, and she's also being attended some of the assurance meetings that we use to manage CCGs, and she's always reminding me of the importance, and it's really good to be able to have this opportunity, so thank you for that. So I don't know where my contents page has gone. Is my contents page here, Martin? Find it? Okay, good. So I was going to begin by describing some of the responsibilities of commissioners relating to PPI, as opposed to sort of direct involvement with patients, because that's where I come in, and that's a bit about what I know about, and how we as NHS England assure ourselves that the commissioners are doing their job. So I'm also going to want to describe some of the evidence that we use currently to look for as part of this assurance process to ensure that the service providers and the commissioners are appropriately engaging and using the information they collect to improve and influence the services that they're responsible for. So I also want to talk about a little bit about the so what. So what's our role if we feel that a CCG isn't performing its PPI duties, and how can we take action to help them or support them to make sure that they are. So just click through to my first slide. So, I think I'm right in saying, although Nikki will probably correct me if I'm wrong, I hope, that the NHS in general is getting better at involving patients in self-care, and we're beginning to appreciate some of the importance of this with the advent of personalised care planning and personal health budgets that some people on the call may be involved with, I guess. And how this is supported through sort of better education of patients themselves for their self-management. And the more we do on this, the more we're learning how important PPI is in improving outcomes to get value for money from services, but also about improving the quality of life and patients. So it's really the role of commissioners, though, that I want to talk about, and I'm particularly keen to explore this, as they've got the responsibility for ensuring that the providers themselves are engaging, involving patients, and using the information that they collect really to their best advantage and to get the most out of that. And of course, when I talk about commissioners, I'm talking about the CCGs mostly, who are responsible for the majority of commission services in the NHS and most of the NHS spending. And I think it's important to stress that the CCGs do have a legal responsibility under the Health and Social Care Act to involve patients and the public in their work. And I've got a little quote here. So CCGs must ensure that patients and carers participate in planning, managing and making decisions about their care and their treatment. So that's pretty fundamental there, isn't it? And they also must ensure that patients and the public are involved in planning and commissioning arrangements. So this is about, the commissioning functions, the allocation of funding, creating these service specifications and changing services. So it's pretty much saying it's a legal basis for the CCGs to make sure they're involved in all of these things. Much of this requirement, of course, is passed on to the providers from the commissioners through a contractual process, and the CCGs are required to have internal functions that manage effectively. So they have PPI lay members as part of their board. We might also expect them to have patient participation groups, and I know that they have those around primary care in most places. Kerno certainly do down here, and a process to manage the contracts, which involves PPI. So who checks the checker? Well, that's our job here at NHS England, but the CCGs themselves do have an internal process where they hold themselves to account through their governing bodies. But my role at NHS England is involved in that, setting up and running the CCG assurance process. And this is a key part of my role down here in the southwest for the CCGs that we cover. So that's Devon down here, Cornwall, and South Devon. So how do we do that check? How do we make sure the CCGs are doing what they should do? Well, we work what's called an assurance framework. And this framework, forget to click on my slide actually, This framework has 5 components. So you can see those 5 components on this slide, and I've just woken up and remember where my slides are. So we check that they're a well-led organisation. That's the first of the components. That they carry out their delegated functions. That they've got appropriate controls over their finances. And that they are performing well against a number of key standards, mostly constitutional standards relating to waiting times, A&E 4-hour waits, cancer, ambulance, arrival times, etc. And also that they have robust planning processes in the short term for the yearly cycle of operational planning, but also the long term in terms of their strategic planning. And so what the assurance process says is that each one of these components will have a number of key factors within them, and PPI comes under the well-led organisation component. So it's kind of difficult. It's kind of like trying to put something in a place where we can then measure it and assure the CCG. So that's where it's been put. The PPI is kind of an interesting one in that it has a thread through the whole organisation and what it does. Perhaps not quite so much around finance, but it certainly does around planning. And so we do have a certain amount of local flexibility around our assurance process where we can say, okay, it goes into your governance and your well-led organisation section, but we would also expect you to see you planning for this for next year and for future years to make sure you're building on the learning and what you're doing already. So to help ensure that PPI is an integral part of this process, it's recommended that through the framework that we have a PPI representative at the formal meetings that take place to assess the CCG performance. And this is an interesting point for me because locally here we've got a bit of a mixed bag in terms of what representation we have at those formal meetings. Down here they happen to be quarterly meetings, but in other places they're only annual. And here we have, like I say, a mixed bag where we have some good representation at those meetings where the interests of the public and the patient are taken there and they're discussed as a core part, but some of those meetings don't. And that's partly to reflect the risks associated with that particular CCG, i.e. they may be particularly good at PPI and therefore they don't feel they need to field someone to be able to talk about it, but I don't think that's necessarily the case. And what I'd be interested to do is get some views on whether or not we feel that it's appropriate not to have representation there or who that person should be. And to give us some examples, the guidance makes some suggestions about who that person might be. So it's given these an example. It's given members of Health Watch, possibly, members of patient groups that we have in a particular CCG area or locality, non-executives of trusts where the CCG doesn't have a contract, and that's to avoid any conflict of interest. And it's kind of an important point because when we do have representation, a PPI representative for these meetings, what tends to happen is they're already affiliated in some way to that particular area. So whilst you would want a sort of impartial review of what's happening in that CCG, what you often get is a description of all the great things that they're doing, and sometimes we feel that kind of overshadows where we would want to get and explore whether there could be improvements. So how does the assessment process work in practice was going to be my next port of call. And how do we factor, the public and patient involvement into the outcome? So we look at a number of items of evidence that are available to us, and that contributes to a performance rating for the particular domain where PPI comes in. I know it's all getting a bit technical now, so bear with me. But in this case, it's the well-led organisation. So in terms of the evidence that we look at, what we have is it's rather limited at the moment, I think. That's another area that really I wanted to try and explore with Nikki. And I know Nikki's going to give us some good examples of other places that probably do this a little bit better than we do down here that we probably learn from. But at the moment, we have a number of sources of evidence. They range from patient surveys, friends, which have been around a while now. But I think that the jury was out about how effective those were and what we could really tell from the results from those. And of course, you have a PPI strategy that puts all the building blocks together. So they've got a coordinated approach. And I've mentioned key lines of inquiry at the top of this slide because this is really just a process that we use here locally to make sure we can ask the right questions to the CCGs and get a response. So if we feel that they're not doing something that we would want them to do, or we've got some queries around their friends and family tests and we want to test those with them, then we've got an opportunity to get those questions to them and get feedback before we take it to a formal assessment. So that's really what I wanted to say there. I've kind of jumped ahead a little bit.
Okay, thank you. Thank you very much, Tobin. Tobin's put 3 questions up here, and we were discussing earlier on to say, well, these are 3 really important and interesting questions. But of course, this is the opportunity for you to ask some questions on what Tobin said or some other issues. So I'm wondering if you wouldn't mind, just for 4 or 5 minutes for question time, putting up your hand. We've also putting up your hand or typing something in the chat box. And just a little note to Tobin and Nikki, for some people the sound quality isn't very good, so I just wonder if you could just make absolutely sure the speakerphone is as pretty close to you as it can be. So any questions in the chat box, or anybody want to ask a question in person by raising their hand? Any questions about the process which Tobin has explained there and the outline of the evidence that's taken in for the assurance process? Any questions at all? Don't be shy. I can't see any raised. Oh, there's a raised hand from Elizabeth Williams. If you could just ask your question, Elizabeth. Thank you.
Thanks, Martin. I was just slightly concerned about the idea of one person sort of representing the PPI voice. I just wondered how you prepare that person, or how do you ensure that they've got lots of information, or that they've had a chance to really assess the PPI going on.
Do you want to answer that, either of you, Tobin or Nikki?
Yeah, I'd like to make a comment. I mean, it's not a new question, but it's a good and pertinent one, and it really is difficult to make sure that you get a range of views to those very senior level performance meetings. So I mean, I had this very same conversation with Nikki a couple of days ago, and it's about making sure that you have an appropriate way of funneling through sort of a body of evidence and views to that person. And it is difficult, it's very difficult, but I think my view on that is it's better to have somebody there than not, even if that person isn't able to talk necessarily for the whole patch and for the diverse range of patients that you've got there.
I think one of the other things as well is that when we sort of move on with some of the examples, I'm going to talk a little bit about what Thames Valley has done in terms of recruiting patients and how they've just evaluated patients sitting on their CCG assurance meetings. And they do indeed have more than one person. So we might get some more examples of that a little bit later on, but you're absolutely right. And it also begs the question that we all sort of wrangle with on a day-to-day basis is about the term patient representative, because actually they're not representative, but actually I'm not sure yet that we've all come together and found out what the right term is.
Okay, so you're going to pick that up a bit, Nikki. So if I just hold that one there for now, Elizabeth. And one more question we've got time for before we move on to the second part. Rachel, could you just say where you're from, perhaps, as well?
I'm from a mental health trust, Sussex Partnership in Sussex. It was really just leading on from the point that Nikki and Tobin and Elizabeth are making. It's not just, I think, about how able and supported an individual is to represent, or whatever word we're using, services or patient views. It's also about how receptive the group that they're sitting on is, and how prepared and how, if they have the skills and experience to work in a way that's open and open to those views. I think it's, you can put the best prepared, most confident, most professional, in inverted commas, patient into a room, but if you've got a group of people who are not able, because of their professional culture, for example, to treat that person as an equal with views to contribute, expertise to contribute from their perspective, you're never going to achieve a good result. So there's something from both ends, I think, around representation of patients.
Thank you, Rachel. Do either of you want to pick that up, or do you want to continue with it, Nikki?
No, I mean, I absolutely agree, and I think we're getting near the time where people in leadership roles are ready. If some of them are there already and some of them are coming. I think now, in terms of the NHS, and particularly NHS England, the time has come where I think the leaders are now getting ready and asking those questions. And And people like me and probably all of you on the phone have been banging this door for many years. So well done to us all, and let's hope we can just take this all forward a bit more day by day.
I mean, we've benefited in our regional team by having close links with, you know, Nikki's team in the quality directorate, because, you know, the people there are trained and experienced in being able to actually receive that type of information and being able to make use of it in a constructive way as part of assurance. But I totally understand what you're saying there.
Yeah.
So it's time for me to say, Nikki, please do carry on for the second half of the presentation, and then we'll have plenty of time at the end for more questions and answers and discussion. Over to you, Nikki. Okay,
so some of this most of you will know already, but this is just kind of bringing us over. How do we evidence patient experience at the moment? And I went to a regional meeting last week within Devon and Cornwall, and we just had this conversation for some time about the fact that we're data rich, and we spent a lot of time about trying to get information, and we've got it for all intents and purposes from lots of different areas. And actually I think the time is right now to ask the question about what do we do with this information. So we've got friends and family, it's all online for most things now, apart from probably pharmacy, that may be coming. We've got complaints data, and we've got PALS if you're in a provider. We've got independent sector feedback from our health watchers, and down here in the southwest, we've been working with all of our health watchers in developing an electronic patient experience feedback tool that all of our local health watchers have on their website and what they have on their iPads when they go out and do consultations. And that electronic tool takes the questions and the answers that people in the local communities give, and it turns it into a dashboard effect of what their answer is. So almost like it changes the qualitative information into a dashboard by giving it a negative or a positive score. So those are some of the exciting things, I think, that we have down here emerging that may hopefully in the future start to be used in assurance meetings alongside some of the things like 4-hour targets in A&E, because actually we all know that you might have waited more than 4 hours, but the experience that you had is very positive. So how do we kind of capture that as well? We've got a plethora of surveys, and we've obviously got place inspections, and we've also got lots of local intelligence, things that just people tell us, and sometimes we need to use that as well. Some of the examples that I'm going to draw upon now are examples in practice are around, I've just spoken about the Health Watch tool. Does it come up? Yeah. I've spoken about the Health Watch tool, so if anyone wants any information, either contact me or one of our local health watchers to see how that's rolling out. Thames Valley, NHS England Thames Valley team have done an enormous project around patient leaders and patient leadership, and this is about a bespoke training program that they've developed and they've just had independently evaluated, where they've been working with people rather than patients, and I think maybe that's quite pertinent as well, and how those people work with people in the CCG assurance meetings that Tobin alluded to earlier. And that training program is 2 half-days worth of training provided by NHS England staff and CCG staff, and the content of it is around understanding the role of commissioning, context and purpose of commissioning, the 5 domains that Tobin spoke about earlier, also the role of the lay member, and the role of also the NHS staff within that meeting. And I think that might draw upon the question that was asked earlier about actually sometimes it's us who need the training, not necessarily the patients or the carers. So if anyone wants any information on that, I'm sure their evaluation can be sent round after the chat, if they're not on here already.
Yes, we can do that. I know that Emma Robinson's in the seminar, and she's very responsible for that. But I have a public document, so I'll make sure that goes on our website and let everybody know after the seminar.
I thought it was also important not just to concentrate on the positive. We also need to concentrate on some of the things that didn't go quite so well. So those are the negatives. So some negative examples that I can provide you that I've come into contact personally with is my background, as you read from earlier, isn't in commissioning, and it isn't even in primary care. It is in cancer and oncology. So when I joined NHS England in the world of commissioning, I didn't actually know that much about it, but I do quite a bit now. But some of the examples that I came across along the way weren't that positive. So one around end-of-life care, which is obviously the top box, was when I went to a commissioning meeting around treatment escalation plans and the use of them in the community. And I went along to give some examples from patients and carers around where they hadn't been as positive as they could be. And I was greeted with a question of, that was 8 complaints out of how many forms that have been given out, Nikki. And I said, actually, if we need to go down the route of accepting what's positive and what's negative in terms of numbers, especially around end-of-life care, then I think we're all in the wrong job. So and that didn't go down well, but actually that was the right thing to do. QIP. I went to a QIP meeting probably about a year ago, was talking about QIP plans with CCGs, and I was there on our NHS England panel to make sure that patient experience was embedded within that process. And I can say from the first meeting that I went to that it wasn't. So in terms of the measurements of success that they were going to report out of their QIP programme, not one of them had patient experience or patient outcomes within it. It has now, so that's great, and that's positive movement. But those are some of the other examples that I want to give you about how sometimes it doesn't work, and actually how we all need to stand up and say, actually, where's the patient in this? And I think that's just becoming more and more commonplace. So next slide is around friends and family tests, which you're all going to be massively familiar with because we've been doing it for such a long time. So we all know that friends and family test is a feedback tool. We also know that it's only one thing within our picnic box, which you can see on the screen there. And actually, if we just thought patient experience was FFT, then we've got that wrong. So we need to fill that picnic box up and make it into a luxury hamper. And today we're going to start talking about some of those things that need to go into that hamper to make it a full and wonderful thing. So, patients as leaders and partners. I had a slight change of heart on this because actually I was talking to a group of patients a couple of weeks ago about patient leadership training, and one of them quite loudly turned around to me and said, I really hate that term, Nikki. I'm not a leader because I haven't got any sheep. And I took that point on board because it was really important. And then I said, well, what would you rather, if we had to call you anything other than by your name, what would you want to be called? And he said, I'd rather just be called your partner, because actually I am. I'm your professional partner. I'm not a leader. I might have those qualities, but that's not who I am. So that was a really important point for me to take on board. So in our 5-year forward view, it says quite clearly that we need to engage with people in new ways. And I think the real emphasis there is new ways, not old ways. There's new ways of doing things, and whether that's technology or face-to-face or just asking different people. I think we just need to start to come up with new ways of doing things. It's like the term, isn't it, hard to reach groups. Actually, they're not that hard to reach because we know where they are. It's just sometimes we don't always choose to go there. Nationally, for NHS England, Patient Leader Expert Advisory Group is something that's been looking at all the little projects that have been going on across England around patient leadership and trying to bring that together to see what that means. And that hasn't resolved in anything coming out yet, but actually it just keeps taking in the information from people. And I think that's really key, because I know for us with what we're terming our new thoughts around our leadership training programme, they've changed considerably in the last 12 months, and some of that is because of what we're hearing coming from other people. So I've talked to you about Thames Valley already. In Devon and Cornwall, we invested some money from a national bid into a patient leadership training programme, now termed patient partnership training programme, for Devon and for Cornwall. The Cornwall one is just about to start, and 25 patient carers or family members will go through that course with the CCG, also with the local hospital. For those of you that may or may not know, Cornwall only has one large hospital, also with the Mental Health Trust and the local hospice. So patients will be going through that programme shortly. For Devon, we're going to slightly mix it up a little bit and try to address that question that was answered earlier around actually how do we bring the professionals on board? Because actually when we went out to advert in the wider community in Devon, we only had 2 applicants received for 50 places. So I think we need to rethink that and maybe just run one course and reinvest that other time and effort into actually working with our NHS leaders, and interestingly had a discussion with South West Leadership Academy about how they may support that. So that's positive news going forward. South West Leadership Academy is also running a course in Torbay looking at working with patients, and it's due to start this week actually, with patients with long-term conditions. And I know that there's 7 patients registered on that programme. So the final kind of thing that I want to leave you with, and it's sort of the question that I seem to say the most in my day-to-day work, is what is the difference between assurance and reassurance? And this is really my biggest bugbear in life, and I just seem to go everywhere saying the same thing. So when I sit in an assurance meeting, I'll give you an example from me, and someone gives me an action plan about what they're going to do that something hasn't gone particularly well. I look at that action plan, and the thing I'm looking for is the column that says evidence. So it's not on the slide that you can see now, but what I want to see is evidence. So if it hasn't got evidence in it, and they haven't thought about how they might measure patient experience within that action plan, then I give it back. And I say quite clearly, that's reassurance. Yeah, you've got an action plan there, this is reassurance, it's not assurance. So go back to your action plan, add in a column around evidence, and then tell me what evidence you're going to provide from patients, carers and their families that tell me that what you've done has made a difference that's positive to their care. So I think we all need to sort of start asking that question, what's the difference in assurance versus reassurance? And if we're not happy with the answer, then just to give it back. So finally, questions from me. They're quite clear on the screen, but I think they are quite pertinent that we need to ask these, and we need to get a feel across the South, and if not wider, about what is your role, or whose role is it within your organisation, and do you know who they are? How would you give patient experience information to someone in your organisation to take to an assurance meeting? How do you share that data in your local area? Do you share it with patients? Do you share it with carers? What do you do with it? How do you close that loop? And can you recognise examples of when you've been reassured now rather than assured? And how are we going to share that good practice? And I think that's the reason why we're here today. Thank you.
Thank you, Nikki, and thank you, Tobin, earlier on as well. So some great ideas coming up, and an exchange of information in the chat box. That's fantastic, including some swapping of contact details. Obviously, at the end, again, with permission, I'll send out email addresses for everybody on the call rather than blind copy, so you can get hold of each other. So we've got a little under 20 minutes for questions and discussion. The process is the same. You can either raise your hand and do that over the phone, or just type something in the chat box, and Nikki and Tobin will be eagerly looking at that as well as me. What I've heard is at least three things which have come up as in the questioning so far. One is the issue about how do we move beyond one person in a meeting, even if, and this is a question for Nikki and Tobin in a minute, even if it is only one person who is allowed to be in the insurance meeting, how do we get around that representativeness or not issue? There's some good suggestions around Health Watch and their role there, but also some comments on the variability in terms of resources and perhaps skill as well. And we've also talked most latterly about if you like, the skill or the training that some people would need, patients as partners, in order to fulfill that role in what could be quite a sort of formal meeting. So there's a few things there, but I'm really just suggesting topics that I'd rather you did. So have we got any questions in the chat box or by raising your hand? Perhaps Rachel could just lower your hand as well, because I think that's from the last time. Any questions in the chat box? I can see some themes and ideas, but anything you'd like to discuss or with each other, or ask Tobin or Nikki? We're scanning the raised hands on the chat box here. Some good little exchanges of information in the chat box. Is any questions from anybody? Yeah, who's that? Yeah, Nikki.
I just wanted to ask the audience, has anyone on the call ever sat in on an assurance meeting?
That's a good question. Can we have any yeses if there are any?
That's interesting.
No, not yet. So Yes, radio silence. So just my super summary of, because Nikki and Toby and I have obviously talked before today, is that there is this meeting. It happens. There's a formal sort of constitution of it. It happens at least annually, but I think Tobin was telling me it could be more often than that if there are concerns. The focus isn't on PPI. The focus is on the assurance process, isn't it? And PPI is an element that both Tobin and Nikki are passionate about getting right. So that's the kind of nature of this this structure, if you like, and meeting. So I think my question back to everybody in the audience is really looking at Nikki's questions here in front of us. Is how or in what ways do you think you could best influence that meeting? Bearing in mind, probably nobody on the call here is actually a person who would normally be attending it. Any thoughts about how you might influence that? Or from Nikki and Tobin?
I think I just want to give you another example, that when we had our recent sub-regional meeting, Luke, I think, was on the call as well, and I sat at that meeting listening to all of our directors present. And we sat there quite candidly counting the times that they said money, assurance, commissioning and patient, and we just wanted to get a feel within 3 hours of chatting about what is NHS England's role, how many times that might come up. And actually I wanted this to reassure everybody on the call that overwhelmingly the first thing that they said the most was staff, and then followed by patients. And I was quite surprised at that, so I even admitted that I was quite surprised at that. I thought the whole meeting would be more about targets, assurance and commissioning, but actually the words that they spoke the most in terms of counting them, which was quite arduous but quite pointedly on them, and was patients and staff, and that was really positive, because sometimes we get the impression that in the NHS that the only things that matter at the moment are money and commissioning.
Okay, thank you, Nikki. We've got a question from Lisa. Lisa, sorry, I think you're...
Can you hear me?
Now I can hear you, so I expect everybody else can. Over to you, Lisa. Can you just remind us where you're from or your background?
Yeah, I'm from Bristol CCG.
Oh, thank you.
And actually commissioning support, working for Bristol CCG. So I just want to check that I understand the question about the assurance meetings. We have monthly meetings with the University Hospitals Bristol, and every quarter there's a sort of patient experience section. So Bristol do loads of analysis and bring loads of feedback about their patients, but there isn't like an actual patient partner attending the meeting, if you see what I mean.
I think that's really interesting, Lisa, because the meeting you're talking about, which I didn't know about, although I'm based in Bristol, is you as a commissioner, or CCG, Bristol CCG as a commissioner, assuring itself about the contract with one of the big main acute providers.
Yes, exactly.
And as a separate, but completely related to today's seminar, a separate issue, it might be that the CCG wants to find out the best way of ensuring that the patient experience is taken into account there. It might be having a person. The meetings that Tobin and Nikki are talking about are, if you like, the next level up to, in a way, for NHS England to check that the CCG is doing that sort of thing.
Right, I see.
Yeah,
so
both
no, then have never been to that sort of meeting.
No, but not to exclude that from our conversation, because the topic today is about how can we assure ourselves that the patient experience is used in the planning process, and you're talking about a really important part of it as well. So if there are others in the seminar today who have CCG or provider experience of how the patient information and patient experience gets into that, let us know. We can raise that as well.
Okay, thank you.
And there's a question to you, Lisa, from Luke on the chat box.
I think I think very much so. I think if we were having, negative patient experience feedback, we would be doing things to address them. I can't think of anything specific offhand. Although actually that's not true. There were issues with the ophthalmology follow-up service that came through complaints and things like that, and that went to serious incidents, and that's all been addressed. So yes, we do.
Thank you. And of course, there's a comment from me here. There's a difference between responding to complaints and responding to the kind of collection of views, the basket of views that Tobin and Nikki have mentioned, you know, of what's that telling us where we need to put our effort. Thank you. So I'll just mute you, but thank you, Lisa, for your question. Tobin and Nikki have got their hand up.
I just wanted to, probably in response to the last question as well, also just, even though we're talking about today about NHS England and the assurance process with CCG, the principles are the same for absolutely everybody. So how do we have a conversation in whatever meeting that we're in to ensure that patient experience is discussed? So if I think about a quality meeting between a CCG and a provider, how does that conversation happen there? A good example is we all talk a lot at the minute about 62-day cancer weights and how people are breaching those. But we don't often talk about, so what's the patient experience for those that have waited too long? So it's just trying to make everyone sort of think about what is the connection to the things that we discuss, be they targets, whatever, but actually how do we link that to patient experience? How do we know from that organisation that patients have been told that they've waited, say, more than 62 days? How do we know that they've not come to harm? So it's just having those, being brave to be able to have those conversations rather than having a particular box on a spreadsheet that says patient experience. Actually, when people just talk naturally about things, I think people that work in patient experience and patient involvement, we all need to start saying things more about, well, actually, so what happened to the patient there then? What evidence have you got to show me that you've told those patients they're waiting too long? So it's just for people to have that thought in their head.
One thing that I think is part of the conversation here, Martin, in the chat box is that Louise and Joe are having a bit of conversation there, and Louise has already told me that she's a qualitative researcher. And what I'd be interested in is how do I get in touch with someone like you, Louise, if we're doing a review, and we are doing a review of cancer services in our local area, and I think most people are. And just to link with what Nikki was saying there about the experience of people who have waited longer than the recommended waiting time, how would I get in touch with someone like Louise so that we could ensure that the CCG are carrying out, you know, one of these patient experience and input reviews? How would I do that? Because that's something that's really important to this process, and it's a bit of a missing link for us in assurance. I mean, you trust the CCGs to go and carry out their work, but if they don't do that, then you know that could be a really important sort of directive action to take to make sure that they're targeting some of these questions at the right services at the right time.
Yeah, and absolutely. But when they do that bit of work, we need to ensure that they ask the right questions that we would all want to know the answer to. So rather than just to come up with an action plan to say how they're going to meet 62 days, that needs to include like the duty of candour about what they've told people who've waited longer. So I think we just need to work a bit better in partnership.
Yeah, Louise, of course, is making the point that most of the things that matter to patients is how they're treated and their experience of the service, rather than them having a conscious sort of understanding of exactly how long they've waited or that they might have a poorer health outcome.
Totally agree.
Thank you. And Louise, did you, you've just put your hand down, but did you want to ask a question? I just spotted.
Can you hear me?
Yeah.
Yes, we can.
Yeah. Okay. It was just in response to how do you get in touch with someone like me. I'm not sure you'd want to get in touch with someone like me because I crawl over it and problematise it. But I think the kind of point is, I think it's about more sort of positive elicitation rather than waiting for complaints or even waiting for patient opinion, but just having mechanisms locally to talk to people regularly and that aren't about measurement and aren't about, you know, can you give us your 5 top answers on this survey, but things where people are able to just talk. Because I think if what you're trying to get is about improving services as opposed to measuring performance, that's where the ideas come from. Just having people chat about, well, this was good, that was a little bit flaky, oh God, and there's that one nurse. That kind of thing gives you more ideas about improving than a number or a response on a friends and family test thing.
Absolutely, I totally agree, and I think that's the beauty of the tool that we've developed with Health Watches down here, is that when patients or carers or members of the public have conversations with them, the conversation can be turned into using statistical analysis. It can tell us lots of different things as well. And I think we have to get better at working with our partners on all of this, because actually we've all become quite fractured in the NHS, and we just need to, I mean, even NHS England and me and Tobin working together, that don't think that happens everywhere across the patch. So we just need to probably get back to some of the relationships, and whoever it was, I think it was Louise said earlier, all this is about relationships, and absolutely it is, and how do we share information? Another good example is where I sat at the Quality Surveillance Group meeting, giving a lovely presentation on what I thought was good outcomes from the National GP survey, to be met by the 5 health watchers who turned around and said, I don't believe a word of that, because actually people are telling us the complete opposite. So that was a good example of actually, in that picnic box, making sure I've got everything in it.
Thank you, thank you. Can I pick up a question from Michelle? Michelle is from Bradford and I'm going to get this right in a minute. Bradford-on-Avon and Melkersham in Wiltshire, Health Partnership, and she's asking to just if we've got any information, and I think I can respond to this as well, around involvement in GP surgeries, because of course the main topic today has been about the big picture process that NHS England is responsible for ensuring. Michelle, again, after today's session, I can point you towards some quite useful things which people put on the Patient Voice South website around GP surgery involvement, and I just wonder if Nikki, because you have done some work on that as well, you'd just like to offer a little thought or tip on that too?
Yeah, so from a primary care perspective, so when I came to NHS England, I was quite noticeable as well that everything we had was about a hospital, and there wasn't a lot about primary care, and that really irked me because over 90% of contacts are in primary care. So we started off by doing a project in Devon, Cornwall and the Isles of Scilly about how to improve PPGs, and that was, I commissioned the Patient Association to lead that, and they've worked with over 200 PPGs locally here, and co-designed and co-produced, and just about to be launched on the Patient Association website, a toolkit, but patients don't like that term, they want to be called an information pack, but for us it's a toolkit, around how to develop a PPG, and also not just in terms of structurally, but also in terms of what they possibly might be able to do in terms of making service improvements in their local community. And another spin-off from that piece of work, we got the local university involved. So Plymouth University were very interested in working out how to get student nurses in particular engaged with patients when they were well rather than when they were unwell. So Plymouth University just in the summer, ran a pilot with 25 student nurses in PPGs, helping them to develop from a health perspective and to start asking questions about their local health profile. And that's dramatically changed the dynamics of how PPGs are starting to think in terms of service improvement of that local area. And we're just about to start the second cohort of student nurses going out across PPGs in Devon and Cornwall. And the evaluation of that, I think, is due to be published soon in a nursing journal. So I'll put that on Patient Voice South when that's out in print. But absolutely, take your point about primary care. But also our HealthWatch local tool doesn't distinguish between place. It just takes the patient experience wherever they are, whether that's health or social care. So that will give us a rounded picture.
Thank you, and thank you very much. And an interesting, thank you for typing your comment or note, Jan. If everybody would like to look at that in the chat box about what's going on about CCGs supporting patient involvement in their local practices. Some really good, interesting things going on there. And so that responsibility does fall in two places. Some CCGs, in my experience in the south of England, do think that patient involvement is in primary care as part of their responsibility, and Nikki's just talked about the southwest. Somerset has excelled itself in that responsibility, and other CCGs have traditionally thought it's the responsibility of the commissioners for primary care, who are NHS England generally at the moment. Is there anything else, Jan, you'd like to say about that? We can put you on the call. In fact, I'm going to put you on the spot. Jan, hello.
Hello. Can you hear me?
We can hear you all right. Very well.
Yes, I mean, this is part of primary care development. I think a lot of the CCGs are moving towards more primary care development as well as commissioning. So my role is primarily to support the practices and to look at ways in which we can improve the role of their PPGs, but as well as fulfilling the questions around innovation within the locality. And it has proved so far to be quite successful. It is a model that we are trying out in Christchurch and Bournemouth.
Thank you, Jan. Well, you've given us a great little kind of intro to that. So if anybody, again, if everybody wants to know more, there's a couple of things we can say. We'll exchange email addresses so you can follow that up individually. But we are going to draw to a close now. So what I'm going to do is really, a lot of that latter bit of our conversation has quite rightly been about the engagement process and the quality of that in places other than NHS England. The main topic of our today's seminar has been around the assurance process to who checks the checker, as I think Tobin's phrase was. So I'm just going to point us towards this question, which is on the screen of Nikki and Tobin's, is how can we, if you're not directly involved, as many of us are not directly involved, how can we assure ourselves or be involved in those NHS assurance meetings? So Nikki and Tobin have told me before today that they're very willing to publish or to give me and give us the contact details of their equivalents in the other patches of the south of England. So is that a yes from Tobin and Nikki?
Yeah, we'll quickly tell them that.
They don't have any choice.
Yeah, you'll tell them. I mean, this is a public service, and we do need to have that transparency. So, thanks for that. So, if you're still thinking, okay, I think this is an important process, I have concerns, or I just want to see how it works, or this issue about, well, there's only one person usually at those meetings, how can we perhaps improve that? Take your local action via your local sub-region, I think it might be called now, for NHS England. So we'll provide those, or Tobin and Nikki will provide those, and I'll kind of make sure they're sent out. So I'm going to just take us towards the end of today, and just say a couple of things, as well as a thank you to all of you, that I'm going to be sending out a quick survey, a very sort of 3-question survey to ask you what was useful today and what we might like to change. But following that, if anybody in the call today is able or willing to share anything, documents, website references, links, that sort of thing, please let me know in the next 10 days. And then week after next, I will put all of those onto the Patient Voice South website and get back to everybody in the seminar today to share that information, including the information which Nikki and Tobin have already said they'll share. So essentially, in the next 10 days or 2 weeks at the most, if you would like to send me, Martin Howard, any information that you're willing to share amongst us here today, I will put that all on the website, and you just need to check that it's that you're happy for it to be shared in that way, and then get back to everybody in about a fortnight's time, everybody who's been here today, to share that information, so that it's not only public to you but to other people who might be searching for it. Lots of things coming up in the chat box in the last minute and a half, so I will